Welcome to this special Best of ECTRIMS short video. I'm John Strum, and just a few weeks ago, I was in Copenhagen, Denmark, attending ECTRIMS, the largest MS research conference in the world. Since 2001, neurologists everywhere diagnose MS by relying on a set of diagnostic guidelines that use a combination of clinical, imaging, and other tests. Collectively, these guidelines are known as the McDonald criteria. And the major news coming out of ECTRIMS this year was the announcement of the first updates to the McDonald criteria since 2017. Following that announcement, I had the opportunity to speak with Dr. Peter Calabresi, who co-chaired the presentation of the updated McDonald criteria. You're about to hear that conversation. Then you'll hear my conversation with Todd, someone who lives with MS, and you'll see and hear Todd's reaction to the news that Dr. Calabresi shared. This video presentation was made possible through a generous grant from Sanofi.
Dr. Peter Calabresi is the director of the Division of Neuroimmunology and the director of the Multiple Sclerosis Center at Johns Hopkins Medicine, focusing on the diagnosis and management of MS. He's the principal investigator on several clinical trials and oversees research projects focused on creating new anti-inflammatory and neuroprotective therapies for MS. Yesterday at ECTRIMS, Dr. Calabresi co-chaired what was probably one of the most highly anticipated presentations at this year's conference, and that was the unveiling of updated criteria for diagnosing MS. Dr. Calabresi, can you explain to our viewers what the McDonald criteria is all about?
Sure. The McDonald criteria are the formal way that we diagnose MS, and they've evolved over the years. Every 5 years or so, we revise them to allow us to more accurately and early on make a diagnosis so that we can get people on the treatments that we have available to them. As we know that early treatment often results in better outcomes, but of course they don't want to expose anyone to a treatment and they don't actually have the disease. So having very specific diagnostic criteria that we all agree upon is very useful.
What sorts of changes were made to the McDonald criteria?
So this past version incorporates several interesting changes. One of them includes the optic nerve as a site that's classic for MS, but hasn't been involved because it's hard to interrogate. You don't see it well on MRI, and only recently has optical coherence tomography been available to see asymmetry or thinning of the affected eye with optic neuritis or optic neuropathy. So this is new, and I think will allow us to identify that site is one of the classic areas that MS can involve. This is useful because many times people may present with a spinal cord lesion, but if they also have an optic nerve lesion, that gives you that what we call dissemination in space or two sites, which is critical for the diagnosis of MS. Some other advances were to incorporate MRI. MRI technologies have evolved over the last 5 years quite a bit, and one exciting one is the classic pathologic presentation of an MS lesion is to have a central vein inside the lesion. We've known this from pathologists for over 100 years, but only can now image this. We can see the blood vessel inside the lesion. And it turns out that if lesions have blood vessels, they're much more likely to be MS lesions than what we call non-specific white matter lesions that could be from any number of vascular processes. So that's very useful. And then another major addition has been to diagnose people so early on that they have what we previously called radiologically isolated syndrome. And we know that there are paraclinical pieces of evidence. So this is like spinal fluid or some of these new MRI characteristics that are so typical of MS that if you have what's in your brain that look very, very typical for MS and you have oligoclonal bands and everything else in the paraclinical categories falling into place, that you can actually be diagnosed with MS at that point because it's so sure that you have MS that why would you wait while you have all these spots in your head to get worse?
Well, now that we've seen some of these changes announced, what happens next?
It's a great question. So it has to be published and peer reviewed. So I think everyone's eagerly waiting. There's a lot of education that has to occur because, as Professor Montalban said, it's complicated. This is perhaps the most complicated rendition of the McDonald diagnostic criteria. So there will be an educational mission at all the major meetings in North America and Europe and around the world. The TRIMS, or the Treatment and Research in MS societies, will help get the message out a little bit and make sure everyone is on the same page. And then there'll be the real world practice of it, getting the radiologist on board to actually look for central vein sign lesions, run the right sequences for paramagnetic ring lesions. And this will be challenging. And one of the things we talked about was in under-resourced countries where it's even challenging to get an MRI, like how much do you have to do? And I think there needs to be some flexibility built into it. So the centers that have all the bells and whistles might do that. But if you're in an under-resourced place, you should still use some of the basics that we have and get people on therapy if they have clinical MS with a positive MRI, basically.
I guess seeing the new complications that are associated with the new McDonald criteria isn't too surprising. As scientists learn more about MS, the science gets more complex, but the understanding actually becomes more clear.
I think that's right. We live in a high-tech world where the technology is evolving so rapidly that we're all trying to embrace it. I think this is true with electronic devices. My kids know more than I do about smartphones and things like this. So we can't bury our heads in the sand and ignore it. So we have to embrace these technologies, use them as much as possible, but also understand that it will take some time to really derive the full benefit from them and for people to get comfortable with them, because some people have been in practice for 30 years are going to find this challenging.
Well, if I can shift gears for just a moment, because I saw you shift gears today and co-chaired a presentation, also very high profile topic on new phenotypes in multiple sclerosis. The conversation, certainly at the beginning of the presentation, revolved around perhaps new course descriptors and updating, just as an updating of the McDonald criteria, perhaps an updating of the terms we use to think about and describe MS. Is it time for that?
It definitely is. And it's a great segue question to the McDonald discussion, because in McDonald, we're incorporating these new technologies and starting to find specificity in biological mechanisms that we associate with MS, central vein and iron rim lesions. And it's time that we start to incorporate that in the descriptors, because what happens clinically, obviously, is very important, but there's something happening under the surface that we know is also very important for long-term prognosis. So there's temporal discordance between when some of these silent white matter lesions form and what the sequela from those can play out 10, 20 years later. A demyelinated axon may degenerate very slowly over time, and we need to incorporate this as much as possible. And so the descriptors are going to try to bring in the biology of MS a little bit more. And so how would we do that? We're still trying to sort that out, honestly, but I think that there are a lot of tools that we have at hand, and there are going to be a lot of discussions about it. But I think we might see some of the purely clinical terms less commonly used, and maybe it'll be like staging of cancer or something where in addition to what's happening to the person, it'll be description of the pathology, how many lymph nodes are involved. Or in the case of MS, it will be what parts of the central nervous system are involved. Is there atrophy going on or not? Are there markers that this person may be headed towards a progressive phenotype? And this will ultimately be good for everyone, because it will inform aggressiveness of treatment. It's my belief that just like in other diseases, there are sometimes benign forms of the disease, and we don't want to expose people to the high-risk drugs necessarily if all their prognostic indicators are in a good bucket. But for a lot of folks who have poor prognosis, we want to make sure we get them on the best therapy as soon as possible.
Well, Dr. Peter Calabresi, I want to thank you for all you do to improve the lives of people who are living with MS. Thanks so much for talking with me today.
Thanks, John. Great to see you again.
This conversation is made possible through a generous grant from Sanofi.
We've just watched my conversation at ECTRIMS with Dr. Peter Calabresi, and joining me to provide some perspective from someone who's living with MS is Todd. Thanks for joining me today, Todd.
Happy to be here.
So can you tell me when you were diagnosed with MS?
I was diagnosed in 2014, around this time of year, so August 2014.
And was that diagnosis relapsing, remitting, secondary progressive?
It was relapsing, yes.
Great. Well, you heard Dr. Calabresi talking about updating the criteria used to diagnose MS, known as the McDonald criteria. These criteria are updated every 4 years. So what are your thoughts on the updates to the McDonald criteria?
I liked it, and following up on the video and kind of looking in to see a little bit more what they had done and removing and I think he mentions that he removed the dissemination through time helps. I was fortunate. I was diagnosed in pretty short order. I was having a pretty severe relapse, and there was plenty of lesions on MRI. So they were able to actually come to a diagnosis pretty quickly. But I have some friends who it's taken a very long time. And, sometimes you don't have all the necessary components to put together the diagnosis. So it's taken a lot longer. So no, I was very happy to hear that. I think that'll be very helpful to a lot of people. And I think getting on a DMT pretty early on is going to be very, very helpful.
Well, yeah, I think you're exactly right. Obviously, we know that there is real benefit to early intervention, but that intervention can't begin until a diagnosis is made. And
Right.
the updates to the McDonald criteria, I think, are going to lead to, and certainly the hope is that it leads to quicker diagnosis, accurate diagnosis, and that means more people getting on the treatment they need sooner.
Yes. Yeah. And great to hear that. Absolutely.
During my conversation with Dr. Calabresi, we also talked about the efforts to update the way we describe MS, replacing the coarse descriptors that doctors have used for the past 30 years with new coarse descriptors that focus on the specific biological mechanisms that are taking place in the central nervous system. What are your thoughts about what will be a pretty significant change?
I'm looking forward to it. Like he said, there's still some kind of putting it together and developing what that's going to look like. But no, I think any way we can clarify it, we can come to a more specific understanding of where the disease is. And he mentions that as well, coming up with better ideas or better ways to treat the disease at various points in the cycle or in the lifetime of the disease, and understanding more clearly where you are and what to do there. Now, it'll definitely be something like, again, still interested to see what they come up with, but good to see they're moving that direction.
Now, when you were diagnosed, I'm curious, how was relapsing remitting MS explained to you?
I'm somebody that goes out and wants to find out. So when I went to my initial meeting after the MRI, there was kind of some hint that it was going to be MS. So I did a lot of research into it. So I had a fairly decent idea, but times of exacerbation or worsening of symptoms followed by a period where it might get better, it might not get better. So it wasn't terribly clear. There was a wide range of things that could happen within that diagnosis and when they would happen. So you go, well, I could wake up tomorrow and I'll be blind. I mean, that's possible, but is that likely? Not really sure. Not really. I don't know. It's not a good way to clarify it, and I guess that's kind of really the problem with the definition. It periods where it's worse and periods when it's not as bad, and it may get better and it may not. And that's pretty much, I guess, what my understanding was of it.
So as we were just discussing, the new course descriptors are going to be focused on trying to relate those descriptions to the biological mechanisms that are actually taking place. Now, we've heard that some of these processes are ongoing, even when you aren't experiencing a relapse or an exacerbation. What do you think about that?
I think it's useful to hammer that point home, because I think a lot of times the expectation is, I'm not having a relapse, all's well with the world, let me stop doing my drugs, taking the DMTs, everything's okay now. And that's not truly the case. The disease continues to work within your body. So it's good to know what's happening there, and to be able to hammer that point home to people, to go, you're not better. You might feel better at the moment, but there's underlying components, there's underlying mechanisms that are happening, and you need to remember that.
Well, the proposed updates to the McDonald criteria for diagnosing MS still need to be published for peer review. And there's a lot more work to be done in developing new course descriptors that more fully reflect the progress that's been made in understanding MS over the past 3 decades. Todd, I want to thank you for sharing your thoughts with me today.
Thanks, John. Appreciate it.